Okay, thanks to everyone for tuning in, and welcome to the Epilepsy podcast. My name is Luke Tomich. I'm joined today by Pradeep Joseph and Rohit Prem Kumar, and our guest today is Aria Fallah. Pradeep, you want to give an introduction?
Sure. Dr. Aria Fallah is a pediatric neurosurgeon at the Mattel Children's Hospital and Ronald Reagan UCLA Medical Center. He's an associate professor of neurosurgery and pediatrics at the David Geffen School of Medicine at UCLA. And Dr. Fallah is an expert in the field of pediatric epilepsy and has performed several hundred epilepsy surgeries to date. Dr. Fallah, thanks so much for joining us today.
Thank you so much for having me.
Thanks. So, Dr. Fallah, we're going to go ahead and get started with some questions. In the topic that we're going to talk about today is hemispherotomy surgery for epilepsy. So there was a 2004 editorial in Neurology entitled Hemispherectomy for Epilepsy. When is one half better than two? I think it was a really interesting way to frame hemispherotomy surgery. So can you first start by just giving us a general introduction of hemispherotomy for epilepsy, and when in fact is it sometimes good for patients to functionally disconnect one hemisphere of the brain?
Yeah, so hemispherectomies or hemispherotomies have now been around for several decades in neurosurgery. They are actually one of the most effective neurosurgical procedures for treating drug-resistant epilepsy. Most commonly, though, it's done in infants and very young children. So this whole idea and the title of that article really refers to the concept that having a bad hemisphere can interfere with the good hemisphere. So in other words, when half the brain or the normal brain by itself without interference from the abnormal side is probably functionally superior to having a bad hemisphere that's contributing to the seizures and affecting or interfering with the function of the normal hemisphere. So this idea is that no brain is better than bad brain. And that's sort of something that we've adopted for now several decades. And again, hemispherectomy is a very rare procedure done in neurosurgery, but a very effective one to treat seizures.
Excellent, thanks.
Great. And this procedure also, of course, is a super specialized procedure, one that even many neurosurgeons won't perform unless you have extensive training in this field. Can you tell us typically how many of these types of surgeries would you perform each year, and how many would you say would be the requisite number approximately to do until you start to really finally feel comfortable doing this type of hyper-specialized surgery?
Yeah, that's a good point. So you're right, as in, most pediatric neurosurgeons don't do this type of operation. And I would say a lot of the residencies out there, you may go through 6 years or 7 years of neurosurgery training and not really be exposed to a single hemispherectomy case. I was lucky in that I, rotated through, I remember Sick Kids Hospital as a medical student, and I saw this procedure done, by one of the sort of giants in the field of neurosurgery. And very quickly, I knew this is what I wanted to do. So I sort of sought out on a path to get as much exposure as possible. Did some training, a sort of enfolded epilepsy fellowship year. And then I picked a neurosurgical fellowship in pediatrics that has a lot of epilepsy. And obviously now I'm at UCLA, where they have a very high volume of epilepsy. So I'd say I probably do about 20 of these a year, and probably over 100 or so, maybe closer to 150 now total. It's a very complex operation, but once you sort of master the steps, once you know the anatomical boundaries of what you're trying to achieve, it becomes a very routine operation. It becomes very, I always say it's a very anatomical operation. So you know where to start, where to end, just based on very familiar neuroanatomy. I will say, just like in all of neurosurgery, I think you learn a lot more with your failures as opposed to your successes. And, early on, when I look back on the first few hemispherectomy cases that I've done, fortunately, I haven't had, complications, but I've had cases where I think I've done an incomplete disconnection. And you sort of need to study them to improve upon, your technique and what you're doing in surgery. So I'd say probably about 5 or 10 operations. I think hemispherectomies are the type of operations, that you become good at and you truly learn as an attending, right? There's operations that you master as a resident. There's operations that you master as a fellow. This is one of them that you kind of need to be in there from, the beginning to the end, to sort of really figure it out. Yeah.
It's a very good point.
Thank you so much. What is the role of EEG in selecting candidates for hemispherotomy? And does EEG or do EEG abnormalities on the contralateral side or bilaterally give you any pause before performing the procedure? And also, could you tell us about the role of PET in patient selection?
Yeah, that's a great question. I mean, the age-old question in epilepsy is, do you follow the pathology or do you follow the electricity, right? So if the abnormality, the clear lesional abnormality that we see on MRI, and if it's only localized to one hemisphere, is that enough, or should the EEG match it? So ideally, I'd say you want both, right? So you want an abnormality limited to one hemisphere of the brain, and typically it's cortical dysplasia, or hemimegalencephaly, stroke, Sturge-Weber, or Rasmussen's encephalitis. Some of them are pretty rare conditions. But it's usually an abnormality of one half of the brain. Equally important, you want to make sure that the normal hemisphere is normal. So you really don't want to do this operation if there's abnormalities on both halves of the brain. And the reason why is you want to rely on that normal hemisphere to really do the work of two hemispheres. So you kind of need that to be normal. You do want the EEG to correlate, but we do know in very young kids, especially when you're talking about specific types of seizure disorders like epileptic spasms, the EEG may not be tremendously lateralized. So it may look like a general abnormality, but we know that those kids can do just as well with a hemispherectomy if the abnormality is limited to one hemisphere. So generally, if I had to choose which one is more important when it comes to epilepsy surgery, I'd say the MRI over the EEG. But in the perfect case scenario, you're striving to get both of them to lateralize to the abnormal hemisphere. So contralateral discharges and contralateral seizures are two different things. So contralateral discharges don't necessarily mean that the normal hemisphere has the ability to generate seizures on their own. If you're getting contralateral seizures, that's a little bit more concerning and gives you a little bit more pause before considering a hemispherectomy. So you may see that in situations of cortical dysplasia or hemimegalencephaly, where the abnormal hemisphere may also have its own potential to generate, the normal hemisphere may also have its own ability to generate seizures. And it doesn't necessarily mean we won't do the hemispherectomy, but it gives you pause. It helps you with sort of patient counseling. And sometimes if one hemisphere is so much worse than the other, you may still do a hemispherectomy for that more abnormal side. In terms of PET, you asked me. So FDG PET was developed here at UCLA several decades ago. This is before I came here. And it was very useful to identify subtle type 1 cortical dysplasia. So this is the type of abnormality that we see generally in very young kids. They generally tend to involve large regions of the brain, up to a whole hemisphere or even more. And the challenge is actually seeing this abnormality on MRI. So FDG PET was very helpful in that patient population and allowed us to identify some patients that would be eligible for hemispherectomy. So FDG PET continues to be part of the standard workup for us, but each center has their own specific workup for these patients and how they approach them. And at some other centers, PET, for example, may be a ancillary test that you get if your initial testing is inconclusive.
That's a good point, Aria. And we sometimes don't get PET in the setting of MCA stroke, for example, because you know that you have loss of brain matter, you're going to see hypometabolism on that side anyway, but it's a good point. Let me go back to something that you said about the technical aspects of doing a hemispherotomy. And you talked about in some of your early cases, you noticed that there were incomplete disconnections. And for sure, there are some studies out there that show that even at some high volume centers, if they get MRI and tractography and carefully look at these post-op images, up to 20% of these cases, even at high volume centers, are still incompletely disconnected. So I think it's not an uncommon issue that you're running up against. Can you talk about where do you see the incomplete disconnections occurring? Are there certain areas of the brain where that seems to be more common?
Yeah, so amongst seasoned epilepsy surgeons, the most common areas, if you were to get an incomplete disconnection, is in that frontobasal. That's the cut that really disconnects the frontal lobe from the rest of the hemisphere, and that's sort of the most common place you can leave tissue behind. Sometimes the frontal lobe gyrus at the back, the rectus gyrus, can be a little bit posterior to your anterior cerebral artery, which is usually what you're using as your landmark to guide where that frontal disconnection is. So that's a very common area. If you start looking at all the different ways hemispherectomies are done, hemispherotomies are done, there are certain folks out there that, for example, don't address the insula, right? So one of the common causes of a failed hemispherectomy is if you don't disconnect the insula from the thalamus, or either undercut it or resect it or remove it. And then, lastly, we also see some surgeons who are sort of now trying things maybe more minimally invasive, maybe with laser and so on, that may not be making all the cuts, all the same disconnections as we do with open surgery. So those are the three common areas where we see incomplete disconnections. But I will say that, our experience has been, even in situations where the MRI looks complete and the DTI doesn't really show us a clear connection, we found it helpful to go back and do an anatomic hemispherectomy. And about 50% of those patients will become seizure-free. That's based on our experience. And we have a phenomenal neuroradiology team, and they'll be able to pick up these things. But, as we know, that each one of these tests has its own limits. Certainly DTI does, MRI does. And I think unless you have a clear explanation as to why the seizures may be coming from the other side, I think it's helpful to go back in and recheck those disconnections and redo them. The big challenge with MRI postoperatively is it's very difficult to tell what's scar tissue and what's normal brain that still may be attached. And the most challenging cases of all are the hemimegalencephalies, the cortical dysplasias, where, if you leave even a remnant, a tiny remnant of tissue, very quickly you'll find out that patient may not be seizure free. At the same time, I will say that, I do have a couple cases, especially earlier on in my career, that the disconnection is not complete, but the patient is seizure free. So there's certainly, and I think all of us have experience with that. And obviously, you don't want to go back and do any sort of redo in a child who's seizure free, but certainly that happens as well. And
saying it's both cases where the disconnection is complete, but they're still seizing, and other cases where the disconnection is incomplete, but they're seizure free. So you see both those scenarios. And that's quite interesting. It kind of segues into our next question. Rohit, if you want to.
Sure. How do you approach the patient who may need a repeat hemispheric surgery? So in terms of workup and the conversation with the family and the surgical technique, specifically like the anatomic, for the anatomic hemispherectomy, how do you approach that?
Yeah, that's a great question. I mean, so the workup, first of all, I'll tell you, over time, this type of work humbles you, right? So usually when your patient's not seizure free, your initial reaction as a neurosurgeon is to defend your surgery, right? Like, this looks complete. I was there. I got it all. There's nothing else. But I will tell you, over time, especially when you work in a team with neurologists and so on, the seizures are back. I think you need to really carefully look at your surgery and be prepared to admit that you may be wrong, and this as experienced as you are, something may have been missed, right? So in those cases, we always do a repeat workup. EEG is very tricky to interpret after hemispherectomy because a lot of tissue is still there. So what you're trying to figure out is, first of all, are there seizures coming from the other side? And is there any electrical activity or abnormality that's sort of crossing over to the normal hemisphere, right? But that will give you a clue as to whether there's a persistent connection. You want to also ensure the patient is having, in fact, clinical seizures. The MRI with DTI is commonly done. And I will say, unless there's a very, very obvious connection, I found it rare that the DTI will show you something if there's absolutely nothing there on the MRI. And to me, I actually find MRI a little bit more sensitive than DTI. DTI obviously is a post-processed image, and you can almost kind of make it look, depending on how sensitive you set the thresholds, you can kind of make it look a certain way. So that's what we usually do. We don't really get PET scans because the whole hemisphere will be hypometabolic. But we really want to see if there's any reason why we would suspect the seizures are coming from the other side. And if not, most frequently we would recommend an anatomic hemispherectomy. And the reasoning for that is several-fold. One is, I always say, when you've done a functional hemispherectomy, we're talking about you've probably disconnected probably over 99%, right? If not 100. And you've kind of already paid the price of a hemispherectomy for those patients. They've already have the contralateral weakness, the hemianopsia that comes with it, but maybe not the full benefit. So in those patients, I do find that, really there's not much risk, and the recovery is not the same in terms of their functional outcomes. They'll wake up neurologically the same, whether you go back and do a redo. Now, the downside of a further operation is the possibility of developing hydrocephalus, and you don't want to take that lightly because, I always say, you don't really want to treat or cure the epilepsy and leave the child with hydrocephalus, which is also another lifelong condition. And that also, we know, affects quality of life a lot. And sometimes those patients may require many, many surgeries down the road. So now when I do go back, and even on our initial surgeries, I do a procedure called choroid plexus cauterization, which is actually a treatment for hydrocephalus. I just do it up front. And we found that our hydrocephalus rates post-hemispherectomy.
This is in the anatomic hemispherotomies?
So no matter what type of hemispherectomy I'm doing, I would do it because, my reasoning is, this is about the only procedure in neurosurgery that has a high chance of developing hydrocephalus, right, after surgery. Almost nothing else that we do, right, in the brain has such a high risk as the hemispherectomies. And there's really no downsides to doing it, right? There's never really been a case of CSF underproduction as far as I know. And you're also literally right there. I mean, it really adds maybe a minute at most to your surgery. And we're talking about a, 6 to 8 hour surgery, and you're adding an extra minute. And we've really seen, at least in our hands, the rate of hydrocephalus much lower than before. And I will say, on first-time hemispherectomies with a choroid plexus cauterization, it's essentially been zero. We've not seen hydrocephalus. Now, redo and the more number of times you go in, I do think there's an added risk. In terms of whether we would go back and try to do a targeted disconnection versus an anatomic, I've tended to go with the anatomic. And the reason why is, when you've done this work for many, many years, you will hear of patients that have had 2 surgeries, 3, 4, upwards of, I've even heard of a child who's had 5 hemispherectomy attempts. And, at a certain point, that's a lot of times to go back in, right? So in my practice, we would do a functional. If that doesn't work, I have to go back in. It's an anatomic, and I've never had to go back in more than twice. And you know, and the nice thing about anatomic is you don't really even need a MRI or anything post. You can, I mean, we do get it, but you know, you physically removed all the tissue. There's absolutely nothing else there. So if the child has seizures, you know they're coming from the other hemisphere. So and from an EEG standpoint, everything, it cleans everything up. So that's what we've done. It's a little bit controversial. I know anatomic hemispherectomies are now rarely done. There's probably maybe a couple places in the country that still do them. And you know, interesting thing for me is I during my training I never did one. So it's one of those things that I kind of had to just learn as an attending. But I do think it's the most definitive way to disconnect the hemisphere. So the conversation I have with the family is I usually quote them a 50-50 chance of seizure freedom. I do say there's a hydrocephalus risk. Now, if they do develop hydrocephalus, I've had success with sometimes doing endoscopic cord plexus cauterization on the other side of the brain. So I don't think we have to just knee-jerk put in a shunt. So we can, you know, there may be other ways to treat it. But the way I present it to them is that we've sort of paid the price of a hemispherectomy, but maybe not have had all the benefits. So, so low threshold to do anatomic hemispherectomy in those cases.
Very good point. You know, I've actually only done one anatomic at this point, and it was in a kid with Rasmussen's encephalitis who recurred after about 8 months. And so far, she's now this was about a year ago, so she's still seizure-free and doing well. But it's yeah, I think it is a very powerful surgery still, and should definitely be part of what we do.
Yeah, it's interesting with Rasmussen specifically, and just as a background, it's a autoimmune disorder, causes inflammation in the brain and seizures. And unfortunately, because it's such a rare disorder, it's hard to generate enough numbers to get great data and great evidence. We looked at our 50+ patients over the years at UCLA, and we found that the anatomic hemispherectomies did better in terms of seizure control compared to functional. And the difference wasn't very evident on short-term follow-up, which is usually a year or two, right? Most of the studies look at 1 or 2 year follow-up. And the reason why is because these patients are usually traveling from far away. It's hard to follow them up long-term. But when you do look at them long-term, the anatomics did better than our functional. So we've actually transitioned. And I realize it's not great data, and we may never have great data, right? With just the way, with how rare Rasmussen's is, but I do now offer them anatomic up front, and I think, I mean, I don't have great evidence, but I wonder if just leaving that inflamed brain tissue in there over time will find its way to you know, to spread in a way, right? So maybe it's beneficial to just anatomically remove that tissue.
That's a good point.
That's fascinating. Just to switch gears really quickly, can you just talk to us briefly about unilateral WADA in your pre-surgical evaluation of patients, and specifically for dominant-sided hemispherotomies? Do you use this all the time, or how often? Like, when do you use this?
Yeah, that's a great point. I mean, I would say in our practice, it's very limited. I mean, generally we're doing, and I'm assuming we're talking about hemispherectomy still. In the hemispherectomies, the vast majority of our patients are very young, 1 or 2 years of age, and we don't worry too much about, you know, memory or language, because we know the most important thing we can do is to prevent epileptic encephalopathy. So try to stop the seizures and then, you know, have the other hemisphere take over. The most challenging patients to treat in terms of decision making are the older patients. For example, one that had Rasmussen's encephalitis, right? And this can present later in age, and perhaps in a, you know, teenage patient, perhaps in the left or dominant hemisphere of their brain. And those are quite challenging. And if we were to suggest something like a dominant hemisphere hemispherectomy in a patient that, for example, has Rasmussen's encephalitis, we would certainly do a WADA, because one of the worst complications you can get in epilepsy is a patient that's amnestic, unable to form any memories. Now, there could be situations where the epilepsy is so severe and the neurological decline is so rapid that it just ends up being a life-saving operation that you have to do. But unfortunately, those patients may not do well long term from a recovery standpoint and so on. So for us, generally, I'd say fMRI has replaced a lot of our need for WADA. We can usually get pretty good language lateralization, and then with comes to memory, there's sometimes that we would consider it. It's still the gold standard, I think, but it's a rare thing that we do nowadays.
Thanks for that answer. Part of the reason we ask that is we do some adult hemispherotomy surgery. I know Bob Gross in Atlanta wrote a big series about his, and occasionally we'll get a case of not a totally destroyed looking hemisphere, but maybe still a pretty good looking temporal lobe on the left side, and some question about is there any residual language function. So we'll sometimes do unilateral WADA in those settings. So I'm going to go ahead and ask what's the last question. Part of the reason we wanted you to be our guest on hemispherotomy is because of your contribution to the field academically. And you came up with, along with your co-authors, the hemispherotomy outcome prediction score. It's something that I found quite useful in my own practice when I'm sometimes arguing for hemispherotomy in cases where it might not be a straightforward decision to make. And so we have to work, as you mentioned, with the whole team and sometimes advocate for the surgeries that we think are going to work. Can you just talk about that process of coming up with that score, writing that paper, putting together a multidisciplinary, multi-hospital team? Tell us about that.
Yeah, so as you know, one of the challenges of just treating rare diseases is that it's very difficult to push the needle forward, right? And each center, each surgeon, their experiences, even over a very long career, may be quite limited, right? And without seeing the large sample sizes that we're used to in our academic studies, it's hard to really argue one way or another. And unfortunately, I don't know if you look, fortunately or unfortunately, when there's very limited data, anyone's an expert, right? So you can come out and say anything you want, and there's really no argument against it. So we're trying to really improve the evidence on which we make decisions in epilepsy surgery. And it turns out that, in our common goal, and we see this in our meetings when we're there, I always find that, even though each one of us seems pretty siloed in our own institution or city doing this type of work, when we come together as an international community, we are all so passionate about what we do and helping our patients, and really feeding off of that passion that we all have is to put together our experiences. So what we did is, myself, Dr. Weil, a few of my colleagues, what we thought of is doing a global hemispherectomy study, right? So we called it the HOP study, Hemispherectomy Outcome Prediction Scale. Our goal was to collect data on 1,000 patients worldwide, and we wanted data from all places, big centers, small centers, every corner of the world. We basically did not exclude anyone who was willing to give us data, and it turns out that we actually got more data than we planned to get, right? We only wanted 1,000 and we got 1,200 and something. And there was tremendous excitement to participate. And what we're able to do is when you get that much data, and, to the cardiologists and the endocrinologists that are used to doing studies on heart disease and diabetes, it may still seem like a small number, right? They usually do studies of 100,000 patients, right? But for us in our field, and anyone who's worked in this field knows that 1,000 hemispherectomy patients is an incredible number. And the power of the data is that when you have that much data, all associations are significant. You can really start to see the signal through the noise.
Yeah.
And what we wanted to do is to really identify the most important factors that determine outcome in these patients, right? Because we always have this discussion in our epilepsy conference, yes, we're going to offer hemispherectomy, but what are we going to coat the family? What's the probability of seizure freedom? And we kind of all say somewhere between 70 or 85%, but it turns out that there are patients that have upwards of 95% likelihood of seizure freedom, and there's ones that are closer to 50. And so that's what HOPS was about. We were able to find a few factors that really helped guide our patient, this patient counseling. I will say, although hemispherectomies are generally very effective, for a family that may undergo or may put their child through an operation like this, and the child may not be seizure free, that can be tremendously difficult, right? You've not only paid the price of a hemispherectomy, but your child continues to have seizures, and it could, so we're not going to avoid all those situations, but it may help us better prepare those families, because ultimately it's the expectation that they have from surgery and the actual outcome. And, the greater that difference between expectation and reality, the more, disappointed they may be if the outcome isn't good.
Well, Aria, thank you for taking time to speak with us. Thanks for, again, that's a really important paper that you wrote, along with, so it's a huge contribution to the field, and it's something that's helped me in my own practice. So we appreciate that. Thanks for taking time to talk about hemispherotomy.
Thank you so much. Thank you for having me. Always a pleasure.
Okay.